So, picture this. You're taking a patient's blood pressure, and all of a sudden their hand just clamps up in a spasm. Or maybe you tap gently on their cheek, and their face twitches. These aren't just weird random things. They're actually classic clues pointing to one really important diagnosis: hypocalcemia. So over the next few minutes, we're going to break down exactly what that is, why it's happening, and most importantly, what you're going to do about it.
Here's the game plan. We'll start with that case of spasms, then dig into why calcium levels fall in the first place. After that, we'll cover how to spot the signs, and then map out the diagnosis and treatment. And we'll wrap it all up with a high-yield blueprint you can take with you.
All right, let's dive right in and solve this first puzzle.
So let's go back to that central question. How can something so routine, so everyday as taking a blood pressure trigger such a wild physical reaction? Well, the answer isn't really in the muscle itself. It's all about the electrolyte that's supposed to be keeping that muscle in check: calcium.
So officially, the textbook definition of hypocalcemia is when the total serum calcium is less than 8.5 milligrams per deciliter. That number is your starting point. But, and this is a huge but, there is a major catch you absolutely have to remember. And here it is. You have got to always calculate the corrected calcium. Think of it like this. There's a protein in our blood called albumin, and it acts like an Uber for calcium. So if your patient has low albumin, it means there are fewer Ubers on the road. The total calcium you measure might look low, but the amount of free, active calcium that's actually doing all the work could be perfectly normal. This is exactly why you can't just trust that raw number. And this is the magic formula that'll keep you from making a huge mistake. You just plug in the lab's calcium number and the patient's albumin level, and boom, you get the true story. This is a non-negotiable, absolute must-do step in your workup.
Okay, so a low corrected calcium is the what. Now we've got to figure out the why. What could actually cause someone's calcium to drop like that?
The key to figuring out the causes all comes down to the body's master calcium regulator, parathyroid hormone, or PTH. You can basically group all the causes into two big buckets. On one side, you've got low PTH states, where the parathyroid glands just aren't making enough hormone. This happens a lot after thyroid surgery. On the other side, you have high PTH states, where the glands are working overtime trying to compensate for another issue, like a vitamin D deficiency or chronic kidney disease. So while the spasms and twitches, it all boils down to this. Think of calcium as a security guard for your nerves, keeping them stable and calm. When calcium levels are low, that security guard basically goes on break. The nerves get super jumpy, hyperexcitable. They're on a hair trigger, ready to fire with the slightest nudge. And that is what directly leads to those spasms. So we get the why. Now for the how. As in, how do you actually spot this in a real-life patient? Let's go through all the clues from what the patient tells you all the way to the ECG. The absolute hallmark feature is tetany, those involuntary muscle contractions we've been talking about. Your patient might also complain about some numbness or tingling right around their mouth, which we call perioral numbness, or just general muscle cramps. But the most dangerous one, the one that is a true emergency, is laryngospasm. That's when the vocal cords spasm and block the airway. It's a can't-miss, life-threatening situation. So how can you actively check for this at the bedside? Well, there are two classic physical exam tricks. First is the Trousseau sign. That's where you inflate a blood pressure cuff and just watch for that very specific carpal spasm. The second one is the Chvostek sign, where you just tap on the facial nerve right in front of the ear and look for a twitch in the facial muscles. Now, here is a really crucial point. While both of these signs are helpful, the Trousseau sign is considered much more specific for hypocalcemia. The Chvostek sign can actually be positive in a small number of people who have totally normal calcium levels. So the Trousseau sign is the one you can really hang your hat on.
Okay, beyond the physical exam, your next big clue is going to be on the ECG. The key finding you're hunting for in hypocalcemia is a prolonged QT interval. It's a perfect illustration of how an electrolyte imbalance can directly mess with the heart's entire electrical system.
And why does that matter so much? Well, a prolonged QT interval is a huge red flag. It makes the heart's rhythm unstable, and that dramatically increases the risk of some really dangerous arrhythmias, most famously that twisting, scary-looking rhythm called torsade de pointes. All right, let's get into the management plan. You've spotted the signs, you've seen the ECG finding. What's your next move?
The diagnostic path here is actually pretty logical. First, you confirm you're dealing with a true low corrected calcium. Once you've done that, you measure the PTH level. If that PTH is low, the problem is almost certainly with the parathyroid gland itself. But if the PTH is high, it's screaming for help, which points you toward a secondary cause, like that vitamin D deficiency we talked about.
Now, your treatment strategy is going to depend entirely on how sick the patient is. If they are symptomatic, they're having spasms, they have that long QT interval, the answer is immediate IV calcium gluconate. You don't wait. But for more stable, chronic cases, the management is different. It shifts to long-term oral calcium and vitamin D supplements.
Okay, let's pull all of this together into one final, super high-yield summary. This is your blueprint for remembering the most important stuff, especially for an exam.
Here are the 5 points you need to lock into your brain. 1. The most common causes are hypoparathyroidism and vitamin D deficiency. 2. The hallmark clinical feature is tetany. 3. The single most specific physical sign is the Trousseau sign. 4. Your key ECG finding is a prolonged QT interval. And 5. The go-to emergency treatment is IV calcium gluconate.
So I'll just leave you with this question. The next time you see a patient who's complaining about weird, unexplained muscle cramps, are you going to think about their calcium level? Because knowing these signs isn't just about passing a test. It fundamentally changes how you approach and care for your patients. And it could help you make a diagnosis that someone else might miss.